Okay, we're going to talk about pancreatitis discharge summaries today, because one of the most frustrating things for the poor surgical reg when they see someone with pancreatitis for the 5th time is not knowing how much of the workup was done previously for pancreatitis. So the idea of a pancreatitis discharge is that you indicate to the GP or whoever is looking at the patient that we've sorted out what's causing the pancreatitis. So to be able to do that, we need to know what are the causes of pancreatitis. So what are the causes, Rose?
Oh, would you like me to go through the causes?
Yeah, you can go through as many as you want, and then we pick on the next person.
So the most common ones are generally either alcohol-induced or gallstone-induced.
Yep. Good.
And then there are less common causes, like inflammatory causes.
Inflammatory. We might give Joan a turn. Specifically in terms of inflammatory, what do you mean by inflammatory causes?
Sorry?
What do you mean by inflammatory
There's
causes?
autoimmune pancreatitis.
Yep, autoimmune.
Like idiopathic, I suppose.
Idiopathic just means you don't know, doesn't it? Right, Joan.
Hyperlipidemia,
Very good.
hypercalcemia.
Jim? Trauma, yeah. Clark.
Post ERCP is another common one, and there's something in their medication list that either has been started or is chronically on there.
Yep. Jose.
Scorpion bite, specifically Caribbean.
Caribbean scorpion, okay, fantastic. Well done, Jose. Anything else? You get the easy ones, Rose. Joan, Jim, anyone? All takers. Malignancy, very good. So, anyone over 40? You've got to think about it. Family history. What else? Jim. Anyone? Jose. Anatoly. So during the admission, hopefully that, and there are probably other causes as well, there's viral causes and stuff like that. And so during the course of the admission, hopefully, we get an inkling of which one of these causes is the cause. Now, fortunately, for most of the time, it's going to be one of these two. So how do we know if alcohol's an issue?
History.
Yeah, history. That's probably the only way, really. Gallstones, how do we know they're an issue?
Any previous presentations or surgery?
No.
We're going to know from both bloods, so if there's...
No. There's just one test we do, really. Yeah, imaging, ultrasound, good. Okay, so ultrasound, and then ultrasound is, they have a gallbladder, and do they have stones? Now, if you go through all this and you can't find a cause and they've still got a gallbladder, you generally get them to have another ultrasound in 4 weeks' time, because sometimes due to the pain, you don't get a great quality ultrasound, and you do it again in 4 weeks to make sure they don't have stones. If they've had their second attack of pancreatitis and you still haven't found a cause, then you generally take their gallbladder out anyway, even if there aren't any obvious stones. Now, we've got a patient on the ward at the moment who's had her gallbladder out. So how do we do we need to worry about stones in her, or do we say no chance of gallstones being cause of the pancreatitis?
Well, I can imagine that the bile will still have to drain.
Yep.
And it'll drain through the biliary tree, so there might be some sludge.
Yeah, so there could be sludge there. Sometimes a common bile duct acts as a pseudo reservoir for bile, and you can get stones down the track. Alternatively, sometimes even though at your best efforts at cholecystectomy, you might have left a stone in the duct, or you do a cholangiogram and the cholangiogram's not perfect, and there might have been a stone left behind. So even if you've had your gallbladder out, you can still have stones and they can still cause pancreatitis. So in that situation, how do we work out whether or not the stones are causing the pancreatitis? Yeah, bloods, maybe LFTs are up a bit. Yeah, you can test their stool to look for gallstone fragments if it's true.
Do you need
The
an
best-
ERCP or?
Yeah, so 20 years ago we would have done an ERCP, but we don't do that now. Why don't we do an ERCP?
Or why don't you?
Because here we don't want to do this to someone, make the pancreatitis worse. So we do an MRCP these
Yeah.
days. And if they're bilirubins or not up, you can do a CT cholangiogram as well as an option. Inflammatory, I tend not to do that unless they've had their second or third attack, but you know, we've got a patient who's had rheumatoid arthritis, so it's probably worthwhile to do it. How do you look for autoimmune pancreatitis? Yeah, IgG4. Lipids, how do we look for that? Fasting lipids, good. Hyperparathyroidism, how do we look for that? Yep,
PTH.
and PTH. I don't do PTH routinely, but if they've had their second attack and you still haven't got a cause, then you can do a PTH even if the calcium's normal. And yeah, I think I've picked up one person with pancreatitis who had a parathyroid adenoma, and once that was taken out, they were fine, but they didn't have a raised calcium. So keep that in mind. Trauma, how do we work that out?
Obviously history and
Yep.
then there's imaging to
Yeah,
confirm.
history and then imaging. Good. Which is usually CT. ERCP.
History.
History,
previous
yeah.
reports.
So if someone's got pain after their ERCP, what are you thinking of? What are the four main complications of ERCP? So pancreatitis is obviously one of them.
Rupture of the abdomen.
Perforation, cholangitis, and bleeding. Usually they have central pain going to the back, or they may only have back pain. They may not be tender. Actually, if they've got pancreatitis, they're tender, but if they've got a posterior perforation, they may not be tender. So it's sort of diverting off the pancreatitis stream, but if after ERCP they've got back pain, think about a posterior perforation and think about doing a CT if your reg hasn't bothered. Medications, what do you do there?
Check sugar resistance.
Yeah, you have to diligently go through every medication in MIMS. Control F, type in pancreatitis. No, Control F, then Control B, because you've already copied pancreatitis. I used to have to go through MIMS, which is this thick, so you guys have got to read this. Scorpion
And so
bites,
even
I
the
don't
newer
know,
ones
history.
that are known, we'd still go through all of the medications because there might be ones
Yeah,
that
yeah.
are common.
Yeah.
Yeah.
Malignancy, how do we look for that?
Family history.
Yeah, family history. So yeah, history, family history.
Imaging, tumor.
Imaging, what else?
Tumor.
Tumor markers, CA19. Okay. What sort of anatomical abnormalities are we looking for?
Division.
Pancreatitism, and usual anatomy of pancreatic ducts. So how do we look for that?
You can do a MRCP.
Yeah, MRCP, good. It's usually a younger person who's had pancreatitis more than once and found any other obvious cause. So, particularly for most people will be one of these two, it'll be pretty obvious. For all the idiopathic ones or the ones where we haven't got a known cause, list out which tests have been done and whether they're positive or negative, and then list out the relevant negatives. So we won't always do a PTH, and you can write down, these are the causes we haven't investigated for. We deliberately haven't investigated for a PTH or an IgG for scorpion bites, and they haven't had an MRCP yet. So that if they get pancreatitis next time, the team knows, okay, well, they didn't have these. Rather than having to have someone go through and know, did they have an MR? Did they have it outside somewhere? And was it at a different imaging place? And as you know, with a system, sometimes the pathology doesn't automatically pop up and you have to search quite far back. If you know that they've already had an IgG4 previously, that can be helpful. Any questions or queries? Okay, good.